Good afternoon. If we can all take our seats, and we would like to begin this afternoon session. I know many of you have not completed your lunch, so just continue doing so. And we will proceed with work that we need to do. I'm going to ask you to multitask, to eat and listen at the same time. Lorraine, Chief Lorraine, can you do that? Can you do that? To eat and listen at the same time? Okay, we're on our way. With that, I'd like to call upon May Cat. Also, she has till 1:30. Dr. Chase, Claudette Chase, will be joining her by virtue at halftime. So with that, I'll call upon May Cat. She's coming first? Oh, apparently Dr. Claude Chase is going to come in first now. So if we can bring her on. Good afternoon, Doctor.
Good afternoon, Wally. How are you?
Sound? Just a minute.
Can you hear me okay?
Yes, you're just coming in.
Okay, good. Nice to see you.
Go ahead, Doctor. You're the first one to make the presentation.
Okay, I'm hoping someone can bring up my slideshow because I'm not very adept at this. There we go. So in talking to May, the goal of this was to talk about bringing services to communities, which is something for people who don't know me, since 1994, I've worked as a physician going into remote First Nations communities. I served Pekanticum for 4 years, Cass for 9, and Yabmatung for 13 years. I'm now semi-retired and struggling with old lady health problems, but was very pleased to be able to join you today. Next slide, please. So we know some of the services that First Nations have been asking for all the years that I've worked here. And rehab services is one of the very important ones because we have so many people with different types of arthritis, and they often end up with deformities that you would never see down south, because people have much better access to physiotherapy and occupational therapy. And a lot of communities have had to take it on themselves to pay for someone to come in and do this. And they can't afford to bring them in even on a monthly basis, which would be the bare minimum. So I know in Yabmatung, there's an excellent physiotherapist, but she was only coming in every 2 to 3 months. So having regular visits by people who get to know the community and build relationship is something that I've heard asked for, and to me makes a world of sense. Usually, even in Thunder Bay, the wait list is long for people who live here. So it isn't an option to send people out for these services for the most part. And really what they need to know is how can they do exercises? What equipment do they need to manage better at home? So having, a physiotherapist and an occupational therapist come in, as opposed to 30 people a month going out, makes a world of sense. The second thing that I've heard asked for over and over is regular visits by counselors the community can get to know and trust, particularly those trained in trauma-informed care. And when this has happened, it's been amazing to me to watch how people who've struggled for years seem to settle down and progress because they're getting what they need at home. They don't have to find sitters for their kids for 3 days while they go out. And for many of the people who are dual diagnosis, have mental health and addiction services, addiction challenges, going out to Thunder Bay or Winnipeg is a mixed bag because they have access to very dangerous tainted drugs that they wouldn't have at the community level. There's always been the request since I started here for more MD services, for the right to see the doctor just because you ask to see the doctor, not because you can prove that you have a terrible health problem. And so currently, because communities are often underserved with doctors, the nurse in charge is left with the unpleasant task of deciding who actually gets to see the doctor. And I think everyone involved in this system would like to see that change, where there's more doctor days in communities and people have better and freer access to seeing the physicians. Again, getting this service at home rather than having to travel for it. Dedicated public health nurses, and May will probably speak more to this. Foot care nurses and podiatrists or chiropodists, they're the same job, but they get called different names. And this is essential with the number of people we have with diabetes and the number of amputations we have, that had people had care early on and adequate care, the amputation might have been avoided. So to me, this is really, again, really crucial. Next slide. Oh, sorry. One other point I would have put on the previous slide, but I didn't, is visiting ultrasound and not just for prenatals, but I think that's really important. But for anybody who's got, we're worried about gallstones, we're worried about pancreatic cancer, early access to ultrasound is important. And years ago, we did have visiting ultrasound, but it was the dedicated service of one person, John Peacock, and he literally ruined his wrist providing service to the northern communities. It was too big a job for one person. So it would probably take 4 or 5 regular visiting ultrasound techs to provide this service. Okay, next slide, please. So then I was selfish and I added my wish list in case this appeals to anyone else. For years, I thought that there ought to be a program similar to the basic radiographer workers program, where local people are trained to do x-rays and do a fantastic job. And there could be a similar program where local people who are trained to be pharmacy assistants, because they're often giving out medications without having a full understanding of what they are, what they're for, how to work with people to tell what they're really taking and what they're not, so that medications can be stopped. And I think that would be something that would be of great benefit to the communities. It would provide employment and be an excellent service. We've had different pharmacies over the years who have made the effort to have the pharmacists do either telehealth or local or visits where they actually travel to the communities. But this hasn't been a regular thing, so we couldn't count on it. The next thing I'd love to see coming to the community, when you think of the number of people we have living with chronic pain, many of whom turn to opiates because that's all they have. And we know the problems associated with that. So to have chiropractors and massage therapists coming in, again, regular basis, the people coming, the community gets to know and trust them, and they do evidence-based practice. I think a lot less people would be drawn towards illicit drugs if that was the case. And the last is for children, specialized trauma therapists. And again, at different times in Yabmaton, we've had art therapists who were amazing, but they didn't stay, they didn't last. There wasn't, I don't know what the issue was, but there wasn't that ongoing basis of forming relationship that we know really helps. Having people who are trained to motivate youth, to get to them when they're younger and before they get on the path of using drugs or alcohol to hide their pain. To me, that would be such an investment. We talk about upstream work to prevent a lot of the problems we see in adults. And I don't think we do enough with children and families to help with that. So that's really, those are some of the things that I would like to speak to. I think in general, having services closer to home by properly trained people who have training in cultural safety to work well with communities, it's, if we really want to improve the health of communities, that's going to be essential. So I'll stop there and let me tell you like it really is.
Thank you, Claudette. Good afternoon. Hope I don't spoil your wonderful sandwiches you had. So I've been many years in NAN communities as well, as a nurse and a nurse practitioner. I was also Jim Morris's health director from 1990 to 1996. And you know, as health professionals, our jobs are to respond to the requests of the leadership. In 2012, when there was a very widespread opioid addiction hitting almost every NAN community, we were asked to provide treatment in some form for the opioid addiction. And so working with community people, we developed a way to do this. And so we took on the treatment part of a four-part way to deal with opioid addiction. Root causes was one of the steps of the framework. But we took on treatment. We learned how to do this new medication called Suboxone. We trained others in the community to work with it. So there's over 25 opioid agonist treatment programs under the authority of Chief and Council, funded by mostly, I think, Indigenous Services Canada. And they're not perfect. We saw the proposals from every community requesting money to do a broad approach, not just providing medication every day to the clients who wanted treatment, but also to do some of the healing part and the trauma work. And that was never funded. Most communities got a third of what they were asking for. So there's still lots of work to do there. Those of you who work with Jim Morris, I know I saw him here somewhere, you know that his favorite line is, "We need a plan," right? So way back in February of 1990, this is how far his plan goes back, he asked the leadership of NAN to approve an approach to working with community health. And that plan was called Primary Health Care, and it resulted in a resolution 9010 and 9011. Why I know that, I don't know. I haven't seen those resolutions for a long, long time. But it was an extended healthcare system that took into not just a curative approach, but also preventative, promotive rehabilitation, like Claudette talks about, as well as supportive, like infrastructure, like housing, clean water. And so that was adopted. The other thing, if you can put my slides up, so the other thing is, Jim phoned me 2 months ago, and he says, "May, do you know where we can find that proposal?" So I said, okay, let's start looking. We phoned Winnie Karuk at NAN. We called Peggy Kinch, who was Jim's public health policy analyst, and we couldn't find this. He phoned me 2 weeks ago, and he says, "May, where's that proposal?" And I said, okay, Jim, let me look. So lo and behold, I found that original proposal dated February 15th, 1990, and that was delivered to the NAN chiefs. In March of that year, the proposal was given to the Regional Director of Medical Services Branch, which is now called FNHA, and it was for $1 million. I guess at that time it was a lot of money. We got refused. The guy said no. You know, when you think about it, a no means so much to us when it comes to healthcare. This was before the suicide crisis. Think about 1990, they were just starting. We've lost over 600 youth, including one this week in Sandy Lake. We've also suffered through the opioid crisis, and now we're trying to pull things together during the pandemic. So when you look at what the plan was real and probably still pertinent 32 years later. So what I'm doing is I'm just giving you the slides from the plan. Oh, I can see it. Okay, let me move this. So go to the next slide. So it's about community participation. And really it's about creating solutions that are suitable to yourself. What do you want? What does your family and community want? And then it looks at community development. Wally McKay, when I first went to work at Treaty 9, was the director of community development. And I mean, I idolized the man. I don't think I ever told him that before, because what he was saying about community development really resonated to, you know, I was a young Indigenous woman at the time, but, and so community development seemed to be the way that really worked well in our communities. But it's a group of people, like all of us here this week, sharing things that we have in common and talking about how to improve life. Oh, I can move this, right? Okay, let me see, here we go. So step one is building trust and listening. And this came up in the small group this morning. But raising awareness within the community of the local health issues. So if you don't have a place to start, that awareness is easy. Don't use jargon. Health transformation gets defined 10 different ways if you ask 10 different people. So let's talk about health services in the community. And then what are the solutions to addressing those problems? And then people recognizing that hope that Stan talked about this morning, and get excited about change. We also looked at step 2 was organize discussions and identify the problem and causes. This morning you talked about the methodology of how do you talk to 25,000 people. There's Jim's plan of action, but it's made for the community makes their own plan of action. And it's really important for the table who has government representatives at them, is that you need to listen to us. You're not listening, Nicole. So one of the things about a community plan of action is government needs to support the work that's being done in the community. This work is organized through the authority of chief and council. We know the first line of authority and self-determination is chief and council. And that was illustrated so well during the pandemic when you locked down your communities, and Premier Ford couldn't understand how you could do that. You did that to protect your people, and you're still doing that, and you have that authority. Health professionals in other sectors, like education, justice, child welfare, we need to assist the community in a healthy, well-being way and listen to the changes that the community's made. And, you know, in some ways, listening is one thing and understanding what the communities are saying. And then you apply your skill set to make that happen. Don't say, I can't do that, that's not my job. If that's what the community wants, you make it your job. So step 3 is government and regional support. We talked a little bit about regional support, about organizations like SLFNHA, NAN, Matawa, Waha, Wabin, tribal councils. Those organizations have been so key during the pandemic. The collaboration, the joint decision making, the planning that went into the rollout of the pandemic. You know, when I think about NAN as a very large geography and so different, there were so many strengths in the way that the pandemic teams and the leadership protected their people. We have to learn that, and we have to apply that to public health. So good ideas are lost without the support of government. This proposal was a good idea. It was lost for 32 years. And you think, you know, it had the approval of the chiefs. We had hope. We got excited until we got a no. And that no didn't stop us. It kept us going in a different way. And it ended up in the creation of SLFNHA. It ended up in the creation of many other things at the community level. But government legislation and policies really make a difference to a patient's journey. So if we had control of those policies, that would really help our patients. Step 4, I like these berries. We had something else in there. I think it was a vegetable artichoke. And I talked to Lauren, I don't think she's here. I said, I don't know how many people like artichoke, so let's go to berries. So step 4 is really about decision to move ahead with something you like. An artichoke is what we have now, right? It's really not, I don't even know how to eat an artichoke, but these things I do. This is from our land, this is from our culture, our community, it's our sustenance, right? So widespread community involvement in decisions, and you can apply that to any problem as long as there's people are involved. Described how those services are to be delivered. Who delivers them? Your community-based workers know your communities best. The talk about training with the tribal council is so true, that we need to start working on that and start building capacity. You have lots of technical resources. I saw them up here yesterday with your tribal councils. As the chair of the NAN COVID-19 task team, I have watched in awe the community response and everybody being able to do a job that they'd never done the day before. I think about the rapid testing for COVID-19, how community people were trained to do that. When I think about the hours of effort to get the policies changed, to recognize that community-based workers can do this job. So that's our presentation on bringing services closer to home. I think our biggest point is as health professionals, we have to be invited in to do a specific job for the community, and we will be there. Unfortunately, we're getting into a situation now where our nurses and physicians are pretty burnt out. We're in a shortage right now that I've never seen, and I've been a nurse for many, many decades. And we need to find a solution to that, and I think we can. You know, it's not only nurses and physicians, there are other people who can come in and help us. And let's look at our traditional people, let's look at our natural caregivers, our movers and shakers in our communities, because they're still there and they want to be involved. So miigwech.
Thank you very much, May, and also Dr. Chase for the presentation on bringing health services closer to the communities. This afternoon we'll be going through a breakout to address some of those things, so you'll have time to address them there. On the next panel, I would like to invite Jamie Cook, Senior Project Manager with Collier's Project Leaders, and also Donna Smith, Bain Smith Consulting. And also I'd like to add to that Donna Gilbreth, who is still with us here to share some of the experiences on some of these things. Hospital Without Borders, okay? We'll have a question and answer period with those three panelists. And I just want to say, there's one question you do not want to ask, and that is, please translate Hospital Without Borders. Okay? We can't, So with those three, can you join us up here, please? And after their presentation, after question and answer period, we'll go into a breakout session again. Hi, who's the,
Jamie.
Jamie?
Yes, that's me.
Okay.
Kicking lights.
Can I get somebody to circulate those? Jamie, can you please come and start your presentation here?
I'm Jamie. Good afternoon, everyone. It's nice to see all of your faces, some of them familiar, some of them new. Can you bring up the presentation? Where did... They said they have 3 different PDFs on it. Yes. Thank you so much. So I first want to start with a land acknowledgement. Colliers Project Leaders has offices across Canada. We acknowledge that our work takes place within ancestral, traditional, treaty, and unceded territories, which continue to be home to many First Nation, Inuit, and Métis people. We continue to benefit from our presence on these lands and are committed to reconciliation. Sorry. This one? Okay. Nope. Oh, did it go? Oh. There we go. So our agenda today, we'd like to cover the timeline of events of engagement to date, previous engagement messages that we've heard over the past year, proposed core principles and draft concept, in general, Hospital Without Borders and our engagement with SLFNHA, community engagement to date, and preliminary concept and discussion. So you can see from this timeline, it starts in 2006 with the Anishinaabe Health Plan, and then March 2017, the non-health transformation process begins. Then SLFNHA in September 2019, there's a resolution 1923, a mandate for new hospitals. Then in December 2019, the Chiefs Board Staff Think Tank report came out. In February of 2020, Minishigawin community engagement. Then the pandemic happened, which slowed us all down. In August of 2021, we were engaged, Colliers engaged by SLFNHA to begin work on Hospital Without Borders, and we began that engagement. And now we're here today to continue that work and to hear from you and to listen to your stories. So previous messages we've heard over the engagement we've been doing. Some of the things include community staff, which we've heard today again, and continue to hear. Wellness model is needed, building capacity, continuum of care, health promotion, all of these important things for your communities to have and should have. Some of the core principles that we have heard and were based on a paper developed in August 2020. Sorry, the slide didn't change. Immediate improvements. Clearly, the people are suffering in the communities and they need to have better health care. Planning, support, and skill development for First Nations. Again, we've heard that today. Wide-scale human resource training, mentorship, and support within the communities. Traditional medicines, It's always valued, and we want to make sure that's incorporated and it's heard. Patients will have a choice to receive access and a choice in what that access looks like. Information and care in their own language. Again, what we've heard today, and we hear all of the time. And collaborative, compassionate, and patient-centered care. Some of the other proposed core principles: quality care standards upheld, provincial system barriers removed, effective and timely care to access, respectful communication, in a culturally safe manner, trauma-informed care, focus on health and wellness, all trained cultural safety, anti-racism, anti-colonialism, individualized care plans. So as I said before, we were engaged last year. Our scope of work that was requested by SLFNHA was to develop a model of care and business case for acute, urgent care, and hospital-type services, labs, diagnostics, etc. Some of these things include elder care also, and long-term care, respite care, so that we are developing a full continuum of care from babies all the way up until the elders. The plan will include models based on community size, community needs, and what the community's choices are. We are going to make sure that what is proposed has their full choice in it. So some of the phases of work that we have done and are continuing to do is community engagement, much like today. Infrastructure review, so looking at water, power, internet, systems, all those kinds of infrastructure pieces that are essential for a healthcare system. A model care overview, business case, and implementation strategies. So community consultations and visits. We are going to be visiting communities with their permission and have them engaged, and as we heard earlier today, with enough notice to make sure that they can fully understand why we're there and participate, because we want to hear their stories. We want to hear what's happened in the past, and we want to hear it from them. We have also, over the past year, reached out to health directors from communities, tribal councils, SLFNHA, Wendigo, Bearskin Lake First Nation, Matawa, community partners like Orange, SLFNHA health directors and managers and their executive teams. So our preliminary concept, as I've said before, is First Nations choice. That's of the utmost importance. Health self-determination, shared network of administration and planning health records, acute care network, and urgent and emergent care. Some other things include holistic care, traditional land-based care, and visiting specialists, and not just general practitioners being in your communities. So our next steps is to continue to listen, learn more about the vision for a hospital without borders. We will use the information we gather today and on all of our visits and engagements to put into our business case and our proposed health system. We have also, I think Donna has passed out a survey. It's either yellow or green to the table. If you would like to fill those out and hand them into the table, the registration table, by 2:30 tomorrow, you will receive a ticket, and there will be a draw held at the end of the day tomorrow there are 5 $100 Visa gift cards available to win. If you feel like you've answered these questions but you want to say more, please write your name and phone number down, and we will contact you, and we will talk to you and hear your stories. We want to hear what you have to say. And I think that's it for me. That's it. Thank you. Oh.
I have Dawn on this, but you're not making any, no, okay.
We were
So-
going to, but now.
Okay, I'll call upon now Donna Gilbert to join us at this time.
All right, I also have a slideshow. Oh, you got it up. Wow, very good. Just say I have a slideshow and it appears. So, hi again. Nice to see everybody. I've really been honored to be here and be a part of your discussions and hear everything that people are saying. It fills me up because, I hear all of you wanting to improve your healthcare system and work together and be in relationship, and that is a good thing. So I'm happy to be a part of it. I'm honored to be a part of it. So I was asked to come here today and to add a little bit more about how we set up our primary care teams. And I know that each of you is unique and you have your own systems and your own ways of doing things, but this is just a different model that we used, and it's just an example of what we chose to do. Now, I don't know why this isn't moving forward. Oh, there it is. Do I have to tell you to move it?
It must not be working. Just let me know and I'll slide it for you.
Okay. All right. So, as I explained yesterday, excuse me, we took the medical model and we completely changed it. And I don't even think I need to use my slides because I can look down here. I brought up my slides here because yesterday I had to look over my shoulder all the time to look at the slides, and now I don't have to because I can see them right here. Or maybe I could yesterday and didn't notice because I was too nervous. I don't know. But anyway, I explained yesterday how we took the medical model and we changed it based on Alaska Native and American Indian culture and values. So we based it on a relationship-based care of system with shared responsibility with customer ownership. And for those of you who weren't here yesterday, customer owners are the people we serve and frequently are referred to as patients, but we use the word customer owners because we believe everybody should come in feeling like a customer and expect that kind of service, and everybody should know that they own their own healthcare system because they paid for it with land and resources. We talked about this story, how important it is. I mentioned it, I just breezed right by it, but story is very important, the story of the individual, and learning who they are as a person is a big part of what we do. We also used complex adaptive system, and I just briefly touched on that too. Next slide, please. And that was the one slide I used on complex adaptive system, and it basically is showing that the customer owner is really in charge and the medical system is really not in charge. And so we changed our system to actually decrease that distance so that we can actually have a parallel process where the medical system can walk with the customer owner on their healthcare needs. Next slide, please. So another one of our premises is that most of the health care that we provide is a service industry, and that changes your whole outlook if you look at yourself as a service industry. It's very rare that you have to have a manufacturing model. In the manufacturing model, it's in certain things like the trauma, the emergency room, surgery, and stuff like that. So that's the only piece that is manufacturing. The rest, it's a service model, and that just changes how you think about something. Next slide, please. So how we applied everything, that top quote, nothing about me without me. That means the person needs to be involved in their own health care. They shouldn't be told what to do. They need to be part of the process. And we also, body, mind, spirit, and emotions, it's the whole person and every aspect of them that is important, and that's the only way somebody can be well is if you look at all of those aspects of a person. And so how do you do that? Well, it's relationships. And as you know, relationships can get messy. You know, there's a lot of details that go into relationships. There's a lot of beauty and wonder and amazement, but there's also messiness too. And so we engage in that. And so we make certain that everybody that comes into our system is impaneled to a team. And the panel sizes are quite small. It's only about 1,200 people per panel. We think it should be smaller. We think it should be about 900 people per panel. And if you actually, I don't know what your systems are, but like in the US, when they have panels, usually their panel size are anywhere from 3,000 to 5,000 people. So our panel sizes are quite small. And it's just it's how we have structured our healthcare system, and I'll get more into that in a little bit. And also we want that relationship piece. So you don't want it to get so big that you don't know the people you're working with. We really want the relationships. So we also minimize the disease-specific approaches, and I've heard a lot of things about diabetes here, and you know, I know diabetes is really important, but we put a lot of focus into preventing those outcomes that can be prevented, such as amputations and dialysis. So we want to make certain that every team is actually optimizing the care of every single person who's impaneled to them. So if they have diabetes, you're optimizing the care for that individual too. And so everybody, you know, the provider and the case manager, they need to know about diabetes, and they need to know how to do that basic care and that preventive care per individual. If a case is too complex, we do have a diabetes clinic also, but we don't rely on the diabetes clinic. We rely on our teams. If somebody goes to the diabetes clinic, they only go there for a referral, maybe some suggestions on meds, and then they come back to their team. So we want to bring the expertise and services to each customer owner when they come into the team. We don't want to send everybody out for everything. We want as much within the team as possible. Next slide, please. So when we took over healthcare, we actually looked at, okay, what was the work? You know, what was the work that everybody was doing? And so, you know, it's basically somebody without a diagnosis. It's for prescriptions, chronic diseases, preventive services, and other referrals. So that's the basic work. Next slide, please. And then we actually looked at how the work was getting done. And so all of these things were going through the provider, and then the provider would refer them off. And when we looked at this model, you know, the thing that becomes pretty obvious just looking at the slide, and you don't have to look at the words, is that the provider is a bottleneck. The provider is slowing everything down. And so we thought about that and thought, well, how can we improve that? Next slide, please. And so we created this parallel workflow redesign where people can get their care within the team, but they don't have to see the provider for everything. You know, an example of that, it would be somebody who needs a medication refill. Maybe somebody has high blood pressure, and they're up to date on their labs, they're up to date on their physical exam, their blood pressure is under control, they just need their medicines refilled. Do they need to see a provider for that? No, not really. They can just get a hold of the case manager, and the case manager can propose an order to their provider, and then the provider would sign off of that. The case manager would also put down, you know, that their blood pressure is under control and that they're not due for anything. So the provider would know that. And so the provider is there, but down at the bottom. And so in this model, the provider is a orchestra director, not a bottleneck. And as a provider, I'd prefer to be an orchestra director than a bottleneck. So next slide, please. So when people are impaneled on their team, it builds that relationship, because you get, not only builds a relationship, but you also get the continuity of care. So if some person is seeing, you know, the same team, the same provider, the same RN nurse and the certified medical assistant, they get to know each other, and it's that treatment plan. sticks with them, and it doesn't change by every single provider, because every provider might practice a little differently, within a certain range. But if you have continuity of care, that actually improves things, and it actually builds trust and builds the relationship. The relationship in itself also builds trust. And when you have that, when you have people who have trust in relationships and can have conversations with their provider, honest conversations, then you actually get to a better plan and you have healthier outcomes. You also, one of the other pieces that we do in terms of care is that same team. They can connect with that customer owner in lots of different ways. So we have an email way that they can do it. They can do it through email, but we also have a system that they can just log into and send it directly to their provider. When they do that, it actually goes to the provider and the RN. So one of them usually picks up on that note pretty quick and makes certain that there's a response to that customer owner very fast. And we also do phone visits too. Next slide. And so this is just kind of an overview of our team on the, I guess it's your right, the circle area. That's the primary care team. So you have the provider, you have the RN case manager, you have the case manager support, and the CMA. And then we also have the integrated care team. So per team, there are these integrated members that take care of 6 teams. They don't go all over the place. They just stay in one wing where there's 6 teams. And so in that way, they're actually getting to know the team is getting to know them, but all the customer owners that are coming in there also get to know these other people. So we have the behavioral health consultants. I mentioned those yesterday. We have an integrated pharmacist. We have dietitians. We have midwives, and we even have coverage providers. So we have the same coverage provider per 6 teams with the same thought process in place that it's built on relationships. So the team gets to know that person, and the customer owners get to know that person. Next slide, please. This is what it looks like. Looks kind of messy, but everybody is co-located. So this is 2 teams right here. And then there are some of the integrated providers in this team. So if you were to see the other end, there's 4 more teams over there. So there's 6 teams per section, and we have it in an open concept like that. Between every team, there's a little bit of a divider, but you can actually see in between all those areas. It takes a little while to get used to it, but once people get used to it, they love it because it actually builds relationship and it builds working together. A lot of times the provider and the case manager are side by side or back to back, so they just turn to one another and have a conversation continually. Next slide, please. So we also have a lot of experts built into our teams, and they support all of the teams. So they can go in, if somebody has a question about certain care, they can help. We have a chronic pain physician, we have a complex adult specialist, and on this slide here, it's complex pediatric specialist, but what we're trying to do is make the pediatricians, like I was describing for the integrated pharmacists, that they're right there with 6 teams. So we're trying to spread out our pediatricians more and support our teams more with pediatric care. And we've done that in some of our areas, but we still need to have more pediatricians doing that. So all of these services are available for all of our teams and for the customer owners. Next slide, please. So this is just kind of a diagram of what I've been talking about. So on the center, very center, is the customer owner. That's how we view things. That's how we deliver care, is understanding that the customer owner and their family are the center of everything that we do. Their primary care team is right around them. Then you have the co-located providers around them. Those are the ones in orange, and then the integrated providers are the ones in green. Now, so everything is right there. You can get all those services when you go to your primary care team. You can get them the same day, we try to make access as easy as possible and services as easy as possible. So we've put a lot of effort into building the most common things that people need. But if somebody needs to be referred out, say they need to be referred to cardiology, they are referred out, and the cardiologist does whatever it is that that customer owner needs, and then the person comes back to their primary care team. So they always come back to the primary care team because that's where they get their coordinated care. And I just want to point it out in our the referral processes. We also have traditional healings, so we consider that as a specialty because if we had an open access to primary care or to traditional medicine, it would be very busy. So we actually treat it like a specialty service. So next slide. So I talked about this, everybody shares responsibility in a relationship to share responsibility. Next slide. And I put this slide in here because it's just a reminder that every customer owner has a story. And if you're in a relationship, you actually get to that story and you're able to understand that person better. The team understands that person, and as a provider and a provider team, you share a little bit of your story. They understand you better, and it helps with the trust. Next slide. This is I just wanted to point out that a lot of our rural clinics are very remote. Most of them you have to fly into. The other thing that I wanted to point out, in the state of Alaska, there are 229 federally recognized tribes. And so all of those tribes had to decide to be involved to manage and own their own healthcare system. And so that was a lot of people and a lot of tribes and a lot of different beliefs. And so within our area, we also have, we actually serve all 229 tribes, but we also have a lot of tribes that we work with very directly and very closely with. And so we deliver this care in rural areas also. It's based on the same model that I just described. So a provider team that I described in Anchorage also has certain communities that are assigned to them, so you also build that relationship through time. Next slide. We use telemedicine. Of course, our providers travel out to those villages. That one picture in the middle kind of shows how remote and small some of our communities are. Next slide. So when you look at this, you actually look at I'm going to talk about the revenues first. So I don't know how you guys do, revenues, or if you even worry about all of that stuff, but we make certain that people, if they are eligible for Medicaid or Medicare, we have support for them to actually get those services, and they sign up for those, and we bill for those services. Only 43% of our budget comes from Indian Health Service. Indian Health Services, where we started, they're the federal government basically who is giving us money to provide this care for people, which is 43%. That's not enough to cover care, so we had to make up the difference, and so we did that through billing, and we did it through grants and research, and also working with the state in terms of reimbursement to make certain it was maximized. And so a lot of our costs, there's, of course, medical costs are varied, and we have a very complex system. But if you look at cost per person in the United States, our costs at South Central Foundation per person are 2/3 of what it is for the rest of the U.S. So, and we've done this through whole system planning for budget and doing the right thing. Next slide. So our system is very high on personnel costs. And how we work this is a lot of people, like all that specialty care, we actually pulled it into the primary care team so that it was centralized, and so we didn't hire a lot of extra people, although we continue to grow all the time. And because of the relationship, because of the teams, we've actually saved money in terms of we now do less labs, less radiology, less prescriptions, less hospitalizations, less emergency room use. So we've actually saved a lot. And so I talked about how we do the parallel workflow. Well, that actually, you're not seeing everybody, and people say, well, if you're not seeing people, you're not making money. And well, that's not true. There's a certain overhead. You're actually increasing the throughput in the financial margin because there's a cost to seeing people too. All right, next slide. And these are the stats, the statistics that we've shown. We've shown a 43% decrease in ER visit. We've shown a decrease in hospitalizations, and if somebody gets hospitalized, we've shown that overall we have a decrease in length of stay for people in the hospital. When you look at our health outcomes, they're stellar. We're better than the national average in the United States on health outcomes, which actually helps to drive down these costs in terms of hospitalizations, in terms of adverse outcomes, and the specialty care that is sometimes needed. So it's the overall system that has decreased the cost for our system of care and improved the health of Alaska Native and American Indian people that we serve. Next slide. And that was it. Thank you.
Does this explain how you cut hospital admissions?
So I had gotten a question while I was up here talking, and it was, does it explain, did what I just explained, does it get to how we decrease hospital admissions? And we did decrease hospital admissions because of the improved health care of customer owners. And we also decreased admissions because when you're in relationship with your primary care provider and you can go see your primary care provider. Like if I wanted to see my primary care provider today, I'd call up and I'd make the appointment. Maybe not at 3 o'clock in the afternoon, but in the morning if I called, I'd get in to see them. I could see somebody if I called in at 3 o'clock, but I could get in to see my provider that same day. And if you can see your provider, then you're not gonna put off stuff. You're not going to put off seeing a provider just because you don't want to wait. You're not going to wait till you have to go to the emergency room. Or some people, they're concerned enough that they just go to the emergency room and then they're seen there. And when you go to the emergency room, of course, you're going to get labs and x-rays and the whole 9 yards, and that's going to drive up costs too. But if you know you can be seen by your primary care team, you will go and be seen by your primary care team and not use these other services. So that overall, decreases hospital admissions. It doesn't happen overnight, but it does happen, especially, once you get those relationships built and that trust built per person, and it works. It really works. I mean, a 43% decrease in ER visits, that's pretty phenomenal.
I had a question about the panels that you're talking about. We don't have panels in Canada, so I'm just wondering, with the panels that you said are 1,200 people, what are your criteria to becoming in that, or getting into that panel, I guess? Like, how is it structured? And how's it broken down, I guess? Like, am I seeing 1,200 kids, or I guess that's my curiosity. We didn't have panels either when we started changing our healthcare system, but it made sense because we took everything that customer owners said they wanted, and then we created a system that worked for our customer owners. So getting into a panel, it's 1,200 people. It's an equal, it's first come, first serve. Whoever, whatever age they can be impaneled. And we encourage families to impanel to the same provider because it doesn't make any sense to be impaneled, to have your kids impaneled to 3 different providers and you're impaneled to another provider. You should all go see the same provider if you want. It's always a choice of the customer owner, but if you can all see them at once, you can actually make all your appointments back to back to back right there and go in together. So that's what we do. We try to do look at panels and make certain that say somebody has a lot of people on their panel with a lot of medical problems, and so we would try to make certain that their panel size was capped at a lower level, and once a panel is full, then they're not going to get any new people, but there's always going to be panels that are open. And so when the customer owner comes in, they're told
what the open panel, what the open panels are and who the providers are, who the provider team is. They're actually given a handout with pictures that describes the provider in greater detail. And they can choose who they want as a provider. And then once that person is full, then they stop taking new people. We also try to limit how many new customer owners come in per provider, because when you first meet somebody, we want them to spend a lot of time with that customer owner and get to know them. And if you do too many, it's kind of overwhelming. So we space it out through time. So many, when we get a new provider in, and if they have a pretty open panel, then we limit how many new people they get per week, just so they're not overwhelmed. So it's a pretty open system, and it's based on customer owner input. Any other questions right now?
Thank you very much. Any questions for the panel up here, including James? Do you have any questions for him? Okay, thank you very much. I want to thank the panel for their presentation. This afternoon you had the sessions bringing health services closer to the communities. Presentations that were made by MACAT and Dr. Chase and Hospital Without Borders. That was the presentation today. We're going to be going into the panels. We're going to go for a break and then go into a panel. And the breakout session is going to be health service innovations. Okay, a number of years ago, SLFNHA had convened a meeting of the minds of the people, and they called it Minachigewan. Minachigewan is to change the system, because the system is not working. We have to change it around. And that is, there was a report that was made about 30 some odd pages. I looked over those things, and there's a lot of good things that were said. So this afternoon on health service innovation, a presentation was made on bringing health services closer to the communities, and also on Hospital Without Borders. I want you to take the time and to try and unshackle our colonized mind, because we have been subjected to think within the reserve and only to try to deal with things that are provided. This afternoon on health service innovation, think of things that you would want to see your children and grandchildren have in the reserve, so that they're not subjected to the same things that many of our patients are being subjected to. Don't be afraid to think beyond what you have today. And we want to know about those health service innovation, different ways of doing things in a new way. Let us go beyond the parameters of what we have now. And we have a lot of people that can provide the advice and also the expertise to be with us. And I think one of the things that we do when we think beyond those parameters, those borders, that sometimes we have a certain fear. Hey, let's be courageous in our thinking, okay? So with that, we'll have a break and then go into the work sessions again. Thank you very much. We'll have a 15-minute break and go back and then we will report back at 3:25. 3:25. I'll see how groups are making. We may extend that a little bit. Okay? Thank you. Also, the summary of yesterday's discussions will be handed out at your group sessions, okay? That's a summary that I